Hi nurse family, it's Nurse Erica here, and today we're going to talk about chest tubes. Now, we're going to do something a little bit differently today, and this is based on the comments that I've been receiving. Some students saying they wish they were in my clinical, they wish I was their instructor. So I kind of wanted to give you an idea or make you feel as if you were in the classroom with me today. I'm going to ask you a question. I challenge you to try to answer right away exactly what comes to mind. Now, you have an advantage. You're at home. Nobody's there to listen to you. Nobody can hear you say the wrong answer. So go ahead and say whatever comes to your mind, obviously within reason. Now, what I love to tell my students, and any student that has me knows this about me, is that I always encourage my students to tell me the first thing that comes to mind, whether or not they think they're correct. And what I like about it is that if they're wrong, it allows me to get them back on track, rather than them going home thinking the wrong answer, okay? So in the sim lab, it's always a safe environment to get the answer wrong and then be corrected so you can go home knowing the right answer. There's no ego here. So let's try this. Now, obviously, this is a new teaching strategy on my channel, so I would love to receive some feedback from you, letting me know what you thought. Do you think this was helpful, effective, or not? Okay, so let's get started. First question. Why would my patient need a chest tube? What are some indications for a chest tube? Now, I'm going to, for the sake of this video, go through main concepts, but I would love for you to answer in the comments more detailed answers, okay? And if you have any questions, feel free to ask me in the comments as well, okay? So, for that first answer, hopefully you said either a pneumothorax. Now, in the comments, you can give me different types of pneumothorax, okay? Maybe you said a pleural effusion. So let's talk about those two things really quickly. So pneumo, right? Pneumothorax is what in that pleural space. So remember, it's not in the lung, okay? Whereas when you have like a pneumonia, right? Or you have a patient who has pulmonary edema, that fluid is in the lungs, or that bacteria is in the lungs. This isn't in the lungs. Where is it? It's in the pleural space. Good. So in the pleural space, what do we have for a patient with a pneumothorax? Hopefully you're thinking air. Okay, so hopefully you're thinking air. Now, if we're going to talk about pleural effusions, there's different types of fluid that we might have in the lung, but more commonly, we might see what? What kind of fluid in the lung? What is it called if I have blood in the lung, in the pleural space? Now, remember when we had air in the pleural space, we had a pneumothorax. So what's another word for blood? Hemothorax, right? So hemo is another word for blood. Hemothorax, blood in the pleural space, right? Then we can also have empyema. So now that we know that our patient today is going to need a chest tube, I want to take you kind of backwards. So I'm going to upgrade you. You're all emergency room nurses. You're the first person to receive this patient. Now, I already gave you a hint. Typically, emergency room nurses do not know what the patient needs from the moment they walk in the door. But you do today. You know that your patient needs a chest tube. What I want you to take you back to is, what led you to believe that? What did you see in your patient that led you to believe that this patient needed a chest tube? So, let's look at my patient here. If we look at my patient here, she looks pretty happy. She's comfortable. Her hair is done nicely. If you look, she actually has decent eyebrows and eyelashes. She's just very nice here, right? Is that how my patient's going to look if they need a chest tube? No, that's not how they're going to look unless I got to them too late. This is post needing a chest tube. I never showed up, right? So let's think about this. Looking at my patient, I did not even touch them yet. How is this patient going to present? All right, maybe anxious, right? They're going to be very anxious because they can't breathe, right? They're in respiratory distress, which my students love to give me that answer, respiratory distress. But what I want to know is, what led you to believe this patient was in respiratory distress? What color were they? Were they cyanotic, right? Maybe pallor, cyanosis, maybe some circumoral cyanosis if this just happened, right? Okay. Maybe a little anxious, right? Maybe in a tripod position, trying to help themselves breathe, right? Okay. If I look at the work of breathing, so remember, I haven't touched this patient yet. The work of breathing, they're probably going to be maybe trying to use their accessory muscles, but if I have a rib puncturing my lung, am I going to be taking nice big deep breaths? No, I'm probably not. I'm probably going to be a little shallow, guarding that space because it hurts every time I take a breath. Okay, and then since I'm smart, I know this is the respiratory system, so all my vitals are important, but what is the most important vital that's going to show me that this patient's in respiratory distress? Respiratory rate. Now, is it going to be up or down? All right, hopefully you said it's going to be up, right? Because if I can't breathe, my body goes, oh, I got to breathe faster. I got to breathe faster because I can't breathe, right? So, all right, all those things I just saw. Now, because I saw that, am I going to go look at this guy's toe? No, I'm going to grab my stethoscope, right? I'm going to listen to his lungs or her lungs. Today it's a female. So I'm going to listen to her lungs. And when I listen to her lungs, what are they going to sound like? All right, well, chest tube is on the right side. So if I listen to the left side, how is it going to sound? Should sound pretty good, right? Unless there's something else going on. Lungs on the left side should sound really good. All right, when I listen to the right side, well, hey, we didn't talk about what this patient had. We didn't say if they had a pneumothorax or a hemothorax for today. We're going to get to that in a minute. But if I have something in my pleural space, what's happening? Well, my lung is not expanding the way it should be, right? My lung can't expand. So since that pleural space, we're interfering with that negative pressure. My lungs like negative pressure, and we're interfering with that. My lung cannot expand. So when I listen to the lung, it's most likely going to be absent. I'm not going to have a strong, nice breath sound on the right. It might be diminished. This is why when you learned in assessment and you learned in your fundamentals course to assess the lungs, this is why we teach you that you're going to listen across, right? We're going to go all the way down and we're listening to both sides, anterior and posterior. Because if I just listen to one lung, hello, I missed it. I missed the whole diagnosis. Right side's not going to have breath sounds or very diminished comparing them to the left. Sometimes there's a slight change, right? It's a small change. And so if I just listen to the right, okay, they sound a little diminished. I'm not really impressed. But if I listen to the left and they sound really nice and clear and I have a nice strong breath sound, then that can really let me see the big picture here, okay? So with that, I'm going to put on a pulse ox on this patient. And is their SpO2 going to be good? Probably not, right? Okay. We're going to do a full set of vitals. We're going to put this patient on EKG. We're going to get some labs. But what diagnostic test does this patient need? Hopefully you said chest x-ray. All right. So patient needs a chest x-ray. So patient, in this case, we're going to take them to the OR and they're going to get a chest tube. Okay. So let's talk about once your patient comes back and gets the chest tube. So my patient comes back and they have a chest tube. Now we're going to talk about what a nurse should do to take care of this patient. So first thing I'm going to do is go ahead and perform some hand hygiene. And I'm going to knock on the door. Hi, I'm Erica. I'm going to be the nurse taking care of you. Can you tell me your name and date of birth? And I'm looking. Okay, Jamie Hill, January 7th, 1984. Yep, that matches my record. How are you feeling today? I'm sure much better from the chest tube, right? Since the chest tube is inserted, I'm sure you're feeling much better. How's your pain level on a scale of 0 to 10? 10 being the worst pain you've ever felt. What's your pain level right now? A 2? Okay, 2 is reasonable. What we want to do is we want to make sure that we manage your pain effectively, because when a patient is in pain with a chest tube, you're not going to be breathing as effectively as we want you to. And remember that we want this lung to re-expand. So we're going to want to control that pain, okay? So if you're having pain, just remember you have your call bell you can ring. Now, what I do want to do is look at your chest tube and make sure that everything looks good. And most likely I'm going to be looking at it a lot through my shift just to make sure that everything looks the way we want it to look, okay? All right, so let me go ahead and grab some gloves. Okay, so I'm going to put a blanket down just because I want to give you some privacy. You are on YouTube after all, right? So now, for the sake of assessing my patient, now let's go back actually. From the moment I walked into this room, I was assessing Jamie, okay? And what was I assessing her for? All of those things that we saw earlier that made us think that she needed a chest tube, okay? So from the moment I walked in, I'm looking at her facial expression, I'm looking at her color, I'm looking at her work of breathing, her respiratory rate. If she's on a monitor, I'm looking at her SpO2, her heart rate, right? Now, every time I'm walking in the room, I'm doing this because at any point, something can go wrong with my chest tube, and my patient is going to be my first sign that something's wrong if I didn't catch it beforehand, right? All right, so what I'm going to do for Jamie here now, she's a mannequin, so she can't move her arm where I want it to be. So I'm going to move her arm up here. In the real world, you don't need to do that. You'll just ask your patient to move their arm to the side, okay? And I'm going to put a little blanket here. Okay. Now, keeping in mind that things are not going to be exactly the way they would be in the hospital, in this simulated environment, we try to make it as realistic as possible. The main thing I want you to know here is that this dressing should be dry and intact. Does it look dry and intact to you? It looks dry and intact to me. And when I feel the dressing, I want to make sure that I'm looking at the entire dressing. If I need to have the patient turn so I can see the back of the dressing, I will, because I want to make sure that this dressing is tightly sealed, okay? That helps to make sure that my chest tube stays intact, in place where I want it to be, but also helps with air leaks, okay? I'm sure you've learned a lot about air leaks and how we don't like them when we have chest tubes. So I want to make sure this dressing is intact. Moving down, I'm going to want to look at my tubing. Now, I should be educating my patient about this, okay? If you notice the dressing is coming off, or if the tubing is kinked, please call me. Sometimes this tubing is, well, not sometimes, this tubing is very thick and very long, and it can get tangled very easily, okay? So you want to make sure that where you're educating your patient, the tube should not be under your patient's leg. It's often found under your patient's leg when they come back from the bathroom, or they were sitting in a chair and now they're in the bed. So whenever you're transferring your patient, you want to make sure that the tubing is not getting kinked, that it's not under them, that the tubing is secure. And that's often a question on the NCLEX, okay? We're always going to secure our tubing. Now, if we look down at the tubing, I have to kind of pull it up a little bit for you. You notice that I have something in my tubing. Now, what is this in my tubing? Can you guys see that? Now, being very careful, because I do not want to lift this tubing up so that this blood goes into my patient. But I have blood here, and I don't want it there, okay? Because what happens is that this blood will eventually clot. So if my blood clots, is my chest tube going to function the way I want it to? No. So what I'm going to do, let me bring this closer so you can see. I'm going to basically help this blood drain into my Pleurovac, okay? Into my draining system. So all I did was lift up the tube and drain it into my drainage system, okay? And we'll talk about that in a minute. Now, every time I walk into my patient's room, I'm always going to look. Now, so now we determined that my patient has a hemothorax because we see that there's blood draining from the chest tube, okay? So patient has blood in their pleural space. So we assessed our patient. Our patient looks comfortable. I'm going to put her arm back. Our dressing is nice and dry and intact. We secured our tubing. We pushed the drainage into the drainage system. Now I want to show you the drainage system and how I would make sure that it's working properly. Okay. So depending on your provider's order, your chest tube might be to suction, okay? Patient's chest tube is on suction. I want to make sure that I review the order and see what the order is for. Now, typically it's about 20 centimeters of water suction. So depending on if I have a dry suction system or I have a wet suction system, I'm going to be assessing it differently. Today I'm going to show you a dry suction, and what I'm going to do is I'll do another video on dry versus wet, so this one isn't too long, okay? So I'm going to want to look at my suction canister. Now, in the real world, I would never pick this up, but for the sake of teaching today, I'm going to pick it up so I can save my knees, okay? So after I've assessed my patient looks comfortable, their vitals are all good, the dressing is good, the tubing is secure. I look at my canister. Now this takes only about a few minutes, okay? So it's not like I'm coming 10 minutes later to look at this. within this little assessment, within 5 minutes, I'm already assessing this chest tube drainage system. And what I want to see is that if my provider ordered suction, I want to make sure that I'm suctioning at the correct amount, okay? So I'm going to look at my provider's order. Oftentimes, in my experience, it's been 20 centimeters of water. But if you look at this system, it goes from 10 to 40. But typically, my provider has always ordered 20, okay? So the first thing I'm looking at is my dial. And my dial here is set to my 20, okay? So you can see that I can change it and set to 20. It's 10, 15, 20, 30, 40, okay? The next thing that I'm going to look at is this indicator right here. And this is why I love dry suction. It's so much easier because all I have to do is make sure that my orange bellow is here to let me know that I'm suctioning at this 20 centimeters of water. Now, here at my head wall, I am suctioning. I have my suction gauge on, okay? And everything looks to be working well. But what really matters is that once my suction is on, I see this orange indicator here that's letting me know I'm suctioning at the provider's order, which is the 20 centimeters of water, okay? Now, while we're here, let's look at our drainage system. We just drained some more blood into the drainage system. So let's look to see where it went. So if you look at the chest tube, this is the tube that it's coming from the patient, okay? It's connected to the patient, and it's going right into here. We have this corrugated tubing to help prevent it from kinking, okay? And it's going right into this drainage chamber. Now, the drainage chamber starts off, if you look, it starts off down here. Now, this would all have blood in it. Somebody must have tipped it over, and so it looks like there's no blood. But this would have blood in it, because what happens is that the blood starts here, it goes all the way up, and after it fills up to the top, it's going to start draining into this chamber, and then it's going to go all the way up and then drain. So it's all the way over here. So can you guys tell me how much drainage this patient has drained already? All right, so let's look at that. And you always want to look at eye level, because if I look at it from here versus if I look at it from below, or if I look at it right at eye level, it's going to be a different number, okay? So what do you guys think? All right, well, if this is 1950, it's not quite there yet. I would say it's about 1945, because each one of these little dashes are 5. Okay? So I'm going to say about 1945. So my patient has drained 1,945 cc's of blood. However, the nurse before me left this little indicator here, and she finished off at about, say, 1900 for the sake of making it simple math. So if she finished at 1900 and I have 1945, I have 45 cc's of drainage during my shift. So let's just explain that a little bit further. So I have 45 cc's for my shift. So in my output flow sheet, I'm going to document 45 cc's. Now, if I was giving you a report, I might say that the patient's total blood loss from the chest tube is 1945. But what am I putting in my output flow sheet? I'm only putting in 45 because I want to give two pictures. The total picture of how much blood my patient has lost from the chest tube, okay, from the pleural space. But I also, more importantly, want to give the picture of what he's lost in the last 12 hours, or she. So thinking about that, as the patient's blood loss is less and less and less and less, we can start considering that the patient doesn't need the chest tube anymore. Vice versa, if my patient was losing about maybe 10 or 15 cc's every hour, and all of a sudden they have 75 cc's of blood loss, I have to think, well, is it because they got up? Is it because they moved? Is it because I'm giving them anticoagulants? If I'm getting more than 100 cc's in an hour, and the patient just didn't receive this chest tube, it's been in there for a little bit, then I might be concerned. I'm thinking about hemodynamic stability and seeing if there's something wrong, right? So we're always looking at the drainage because it tells us a lot of different things. All right, let's look at the next compartment. Okay, so remembering that this is a dry suction chamber, notice that we still have a water seal, and the water seal is what's going to tell us if my patient has an air leak. Okay, so you see that they have different numbers here. The grade of air leak will depend on how much bubbling I see. All right, so here I have no bubbling and my water line is at the 2 centimeter mark where I want it to be, so that's good. Now, if my patient had a pneumothorax, there may be an occasional bubble right here, and that's normal considering that there's air escaping from the pleural space. It might come into the chest tube, and that's okay. Now, oftentimes there's a little ball here that you might notice go up and down as the patient breathes in and out, and that's called titling, and that is normal. If the ball is not going up and down, that could mean either the chest tube is blocked and it's not working, or the patient's lung has re-expanded. So obviously we're going to assess the patient to assess which one it is. And then lastly, we'll just go back over this to give you a nice pure clear picture. The dial is set to 20. Remember, we're looking at our provider's order. Depending on our provider's order, we're going to do 10, 20, 15, 20, or 30. More commonly, I see 20. And we're making sure that our orange bellow is there to show us that, yes, this is working. I just wanted to show you what it looks like if the orange bellow is not there. So you see that there's a little window there and there's no orange bellow. So that could just mean that my provider has ordered to stop suction. But if my patient is supposed to be having suction, this orange indicator should be there. And as long as this is set at the 20 and the orange indicator is there, that means I'm suctioning appropriately. Okay? Okay, so now let's go back. The first thing we talked about is knowing when my patient needs a chest tube and why my patient would need a chest tube. Okay? We talked about how to assess this patient, how to determine if this patient is having trouble with the chest tube, right? When we walk in the room, looking at them, seeing how they're doing, assessing for any respiratory distress. We talked about how to educate the patient, making sure that the tubing is secure, making sure that they're well medicated for pain so that they can breathe effectively and move around in the bed, okay? And then we looked at the tubing, we secured the tubing, we looked at our dressing was dry and intact, we drained the blood into the drainage system, and we also measured how much we have. Now what we should talk about is how are we gonna assist this patient to re-expand the lungs? Besides the chest tube, there's other things that we should do. Okay, so we talked about pain management. What else can we do to help this lung re-expand? All right, so hopefully you said sit the patient up. Now, if the patient is hemodynamically stable, this patient should be in a chair. Okay, they should not be lying down. What do we always say we want to do when our patient is having trouble breathing? What is a simple thing that we can do? We sit them up, right? So that we can promote that lung expansion. All right, the next thing you probably saw, incentive spirometer. Incentive spirometer is very important on this patient, and it's often ordered every hour, depending on your facility, depending on your provider's order. Typically, you want to encourage your patient to use it about how many times an hour. All right, so in all the facilities that I've ever worked with, we always encourage our patients to use this at least 10 times every hour if they can, and that's where the pain management is so important. And how would we use this? Is my patient going to blow into this, or is my patient going to breathe in? Now, one thing that I always do when I come in to meet my patients, I always say, hey, can you show me, have you been using the incentive spirometer? And they say, yes, I've been using it. And then I say, okay, let me see what you got. Let me see what your skills, how we're doing, right? Make it like a game, make it a challenge to encourage them, because this is something that we can see progress as we're getting better, right? And what happens many times is that they blow into it, right? And they're just becoming blue in the face trying to blow into this. And if you think about that, if you think about the fact that we're trying to expand the lungs, blowing into this is not going to help. What we want to do is take a nice big deep breath in. So we want to encourage our patient to be sitting up in the bed. We're going to have their lips tightly wrapped around and take a nice big slow deep breath in. And I always teach my patients, think about it. Take a nice big deep breath in. Everybody, let's do it again together. And let's hold it. I want you to hold it. 1, 2, 3, and let it go nice and slow. Now I want you to take a big fast breath in. Which one of those expanded your lungs and is going to help to get those alveoli open, and it's going to help to move that junk that's in your lungs? Which one? Think about it. Or, all right, so hopefully you said the first one. We want to take a nice, slow, steady, deep breath in, hold it for a few seconds, and then release it, okay? And during that time, this little yellow indicator should stay in this window. And that's what we're looking for. We're not only looking to see how high, that's okay, how high they can get this, but we're also looking to see if they're able to hold that breath. Now, in most cases, in the beginning, they're going to struggle with this a lot. So we want to get them up in the chair, use the census barometer. Some of my patients absolutely cannot do this at all, and they become frustrated and anxious about it, and that's the opposite of what we want. We want to encourage. So what I often will do is speak to the provider, and we'll talk about taking nice big deep breaths in and holding it, and I do it with them every time I walk in the room. Okay, take a nice big deep breath in with me, let's hold it, and let's out. And oftentimes that's going to be a lot more positive for them. If they're struggling with this, we still want them to be doing their breathing exercises. All right, let's talk about, so we said getting them out of the bed, chest PT, census barometer, pain management to help re-expand that lung. And they'll be doing a chest x-ray daily to see how the lung is doing. They'll look at the drainage if it's a hemothorax, and that's how they're going to start to determine if the chest tube can come out. Now, sometimes the chest tube comes out without us being ready for it to come out. So it's very important that we have a few things at the bedside, okay? Now, depending on your hospital facility, you might just need regular 4x4 gauze, or you might need a petroleum dressing, which is just a Vaseline gauze, and I'll show you what that looks like, okay? So it's very important that you know what your hospital policy requires. Your textbook might say the same thing. So for your test purposes, go ahead and look at your textbook and go with what your teacher has taught you. But this is basically what the petroleum gauze looks like, okay? It's a Vaseline gauze. And I also have my hemostat, okay? So this is if I need to emergently clamp the chest tube, or if the provider asks me to clamp it, okay? If my chest tube comes out, I'm going to go ahead and put the appropriate dressing. Like I said, it might be just a regular 4x4 gauze, or it might be a petroleum dressing. Whatever I'm going to do, I'm going to go ahead and put it on and tape the 3 sides, and one side is going to remain open to prevent. Remember that we can cause a pneumothorax if we completely seal it. So 3 sides, okay? And then obviously it's an emergency, we're going to call the provider. Sometimes what could happen, and I've seen this more commonly, is that somebody comes by and knocks over the chest tube, and the drainage system can break, okay? If it breaks, then at the bedside, I should have had my sterile water, and what I'm going to do is I'm going to go call Becky, go get me another drainage system, and in the process, I have my chest tube into my sterile water. Now, what does that do? Well, this is what's so cool about nursing. Remember when we looked at the water seal? It allows the air or whatever drainage that needs to come out to drain, okay? However, it doesn't allow air to go back in. That's what the water seal does. Well, this is what this does too. So I'm going to go ahead and put that tube, the patient's chest tube, into my sterile water, because that's going to create my water seal to prevent air from going into my patient's lung, because I don't want to cause a pneumothorax while my colleague is getting me a new drainage system, okay? Also, sometimes the chest tube system does not break, but remember when I showed you the drainage, how some of the drainage was in the other compartments? If that happens, we need to change the drainage system, okay? We can't use the drainage system like that because you're not going to be able to accurately measure your drainage. So what you would do is you would go get your new drainage system, and you're going to get it everything ready. You're going to get everything ready, the suction, everything, and then you'll clamp within a couple of seconds. It's like less than 10 seconds. You're reconnecting it to the new drainage system, and you're going to unclamp the tube. Okay. That you might also have to do if your system becomes full. So remember, how to assess the need for it. We covered how to assess our patient, how to manage them, how to help them re-expand their lung. Now let's talk about if this chest tube has to come out. If the chest tube is going to come out, it's often done at the bedside. At least in my facility, we always did them at the bedside. You're going to have an x-ray in the morning that confirms that the patient's chest tube is ready to come out. The patient is stable, they look good, their breath sounds are equal, and the provider is going to ask you to gather some supplies, and that's usually going to be a suture removal kit, your Vaseline gauze or your dry dressing, some sterile gloves for the provider, and you're definitely going to want to medicate this patient so they're not in pain. Before the provider does the procedure, you're going to want to teach the patient about the Valsalva maneuver, because remember, as that chest tube is coming out, we don't want air to get trapped in that pleural space. So we're going to have the patient take a nice big deep breath in and bear down to kind of help prevent that. Okay. Once the chest tube comes out, it's your job to monitor this patient to make sure that they're tolerating it well. Okay. So what are we looking for? Well, we're looking at our patient. Are there any signs that they're having respiratory distress? All of a sudden their respiratory rate is going up. All of a sudden they're using accessory muscles, or they're shallow breathing, or their SpO2 is going down. Patient is getting a little anxious. Okay. Listen to the lungs. They're more diminished. We're going to want to get an x-ray, see how they're doing. So it obviously isn't something that we like, but sometimes the chest tube has to go back in. So just remember, chest tube is out. That doesn't mean that the patient is okay. We're still going to be monitoring them to make sure that they tolerated it well. All right, so I think we covered everything that we needed to cover about chest tubes. I'm going to do another video on the wet suction versus dry suction, so go ahead and look for those. And in the meantime, please feel free to let me know what you thought about this video in the comments. I hope it was helpful to you, and good luck. Bye-bye.